Hi, I'm now going to talk to you about hypertensive emergencies. And there's a blood pressure shooting up. So, if we pick a classic example, a 56-year-old male with 2 days' history of increasing agitation and drowsiness, he's been mildly hypertensive for a few years, and he presents with a high blood pressure, 230 over 130, no focal neurological signs. A GCS is a bit low at 11. He's got evidence of retinopathy. Chest is clear, he's passing urine, he's got left ventricular hypertrophy, signs of on his ECG, and moderate cardiomegaly on his chest x-ray. So the four questions I'll address in the talk is: what do we give him to lower his blood pressure? How quickly should we lower it? To what initial level? And what monitoring do we need in place? And as I'll show you later, there are trials, for example, in stroke medicine and control of blood pressure. However, for the vast majority of other hypertensive emergencies, there's very little control trial data. I'd recommend these guidelines to you. They're American, the American College of Cardiology, American Heart Association. They revise them every 5 years or so, and these are the 2017 guidelines. And this is how they generally apply categories of blood pressure: normal, below 120 systolic, below 80 diastolic, going up all the way up to stage 2 hypertension, where the systolic is over 140 and diastolic at or above 90 diastolic. So let's talk about urgencies. And the urgencies obviously are less severe than the emergencies. The blood pressure is high, but the patient's otherwise stable. There's no obvious evidence of impending organ damage, organ dysfunction. They may have stopped or aren't compliant with their treatment. It's not an emergency, but to a large extent, the treatment's about intensifying or making sure they take their drug therapy. And if they're anxious or in pain, that needs to be addressed. So there's no need necessarily for these people to be referred or admitted or to rush and lower their blood pressure. So with the urgencies, ideally you want to reduce the blood pressure over a 24-hour period or so. There may be some symptoms like headache or shortness of breath or epistaxis. And if you look at the clinical presentation for urgencies, headache, faintness, epistaxis, and some degree of psychomotor agitation represent the main presenting features. The recommendation is to give an oral short-acting agent, because there's no evidence to suggest a more aggressive approach actually offers any benefit. And clearly it's to make sure the patient is compliant, or the dose of their long-standing medication needs adjusting, and they need to be followed up after a few days. The emergencies are obviously more life-threatening. They're defined as a severe elevation in blood pressure, so over 180 systolic, over 120 diastolic, with evidence of new or worsening organ dysfunction. And if left untreated, many of these patients are dead within a year. Is it the actual blood pressure itself? Perhaps, perhaps not. It's the rate of rise that seems to be critical in the development of organ dysfunction. And clearly many chronic hypertensives, especially if not poorly controlled, often have high blood pressure levels. The presentation, a whole variety of things. It may be chest pain or dyspnea, neurological deficits. They may have had strokes as a presenting feature, or be it infarction or bleeds. They may be encephalopathic. They may be in heart failure. So clearly, if there's a cause that can be identified and treated, that should be done. Often no cause can be found, so it's malignant hypertension without another etiology, but it's important to rule out renal disease, clearly in pregnant women, eclampsia or preeclampsia, hormonal conditions like a PHEO, raised intracranial pressure. Often, especially with recreational drug abuse, we see a lot of drug reactions, and especially with people taking multiple drugs, drug interactions may play a part. There may be aortic dissections, coarctation to worry about, and good old-fashioned anxiety, agitation or pain are very good ways of elevating a patient's blood pressure. Treat those, and often the blood pressure controls itself satisfactorily. So the aims of our presenting or initial management is to prevent or limit organ damage by recognizing it promptly and starting appropriate therapy at an early stage. So yes, the blood pressure needs to be reduced, but not necessarily to a normal value. So you want to take the edge off that blood pressure initially and then can lower it more gradually thereafter. As a few examples of target organ damage, they may have a brain problem, encephalopathy, stroke, a bleed, a heart problem, renal failure, etc. So in terms of what drug to use, again, there's no hard and fast rules over which drug is better or worse. So I would argue familiarity is probably the most important factor. Be familiar with how the drug works, the pharmacology, how it can be used, and obviously with that familiarity comes a recognition of any potential problems or complications that the drug may cause. Clearly with a view to treating the underlying pathophysiological factors dictates or drives you towards some drugs more than others, and I'll go through a few examples later on about that. And obviously you've got to then work out where the patient needs to be, how quickly do you want to lower that blood pressure, and obviously taking into account how rapidly they are deteriorating clinically and whether or not they've got underlying comorbidities. So let's talk a little bit about treatment. Although there's no RCT evidence that antihypertensive drugs acutely reduce morbidity or mortality, it is highly likely that this is a good thing. As I mentioned before, there's no strong evidence to say which is the best drug to start using first. The trials are generally quite small, there's lack of long-term follow-up, and often a failure to report outcomes. Yes, we've lowered the blood pressure, but what happens to the patient? I would agree, I would agree with this statement, especially if there's an emergency, that ideally a short-acting intravenous agent that can be easily titrated is preferable if you want that close control. There are some exceptions to the general recommendations for lowering blood pressure. With an acute ischemic stroke, I'll show you some of the literature, but there's no evidence to support immediate antihypertensive therapy unless that blood pressure is very high. With acute aortic dissections, here you have to be more aggressive in lowering the blood pressure, ideally to get the patient down to below 120 systolic, unless obviously they can't tolerate that low blood pressure. If you're going to use thrombolysis, then there are sort of recommendations as to what blood pressure it's safe to start at, and I'll add in, and it came into my talk on left ventricular failure, but I think there's another good example of somebody who's hypertensive and acute heart failure. You want to lower that blood pressure relatively quickly to allow the left ventricle to pump more easily by reducing the systemic vascular resistance. So in terms of treatment, the conditions where you need to be more aggressive in lowering systolic blood pressure, usually to get it below 140, include, as I mentioned, aortic dissection, the eclampsias or the severe preeclampsias, and the pheochromocytomas. Except intracranial hemorrhage, there's no good RCT evidence comparing different strategies to reduce blood pressure, and little evidence as to how quickly, by how much, we should be lowering the blood pressure. clearly there's this balancing act. On the one hand, you don't want too high blood pressure. On the other hand, you don't want to drop it too quickly. That may impair organ perfusion. So lowering the blood pressure rapidly is not without risk, and giving lots of oral loading doses, there may be cumulative effects. So for example, in stroke, you've got this balancing act between keeping the blood pressure too high, risking a repeat hemorrhage or a new hemorrhage into an infarcted area, for example, and increasing the risk of brain edema. On the other hand, if that blood pressure is too low, perfusion pressure to those ischemic areas and the surrounding penumbra may not be maintained, and obviously if you're critically affecting perfusion, that may increase the size of the eventual infarct. Okay, let's go through a few trials. This is the Interact 2 study in acute intracerebral hemorrhage, came out in 2013. Nearly 3,000 patients, and they were randomized within 6 hours of having the bleed or presenting with the bleed to either get the blood pressure systolic below 140 within an hour or below 180, and they try to maintain it at that level for 7 days. And as you'll see, there's a bit of a trend, but it's none of it significant towards intensive treatment. So being more aggressive to get that blood pressure down. And as you can see, in terms of the primary outcome, which was a composite of death or major disability, there was an absolute reduction of 3.6%, and it wasn't quite statistically significant, but it was nearing so. A criticism of this trial, and unfortunately many other trials, is the investigators didn't follow the protocol. So only a third of the patients achieved that systolic blood pressure target within an hour. So would the outcomes have been significantly better or maybe worse had the other 2/3 got to that target value? This is a trial came out the following year in JAMA. It was patients with acute ischemic stroke, and about 2,000 patients were randomly assigned to receive blood pressure lowering therapy to reduce it by 10 to 25% within the first 24 hours to achieve a blood pressure below 140/90 within a week, or basically to discontinue all hypertensive medication during hospitalization. And as you can see, they were quite good at maintaining separation in blood pressures between the control group and those treated with antihypertensives to try and keep the blood pressure below 140/90. And it made absolutely no difference in terms of likelihood of death or major disability, either at 14 days or hospital discharge. This other study, the SCAR study, looked at patients with acute stroke who received candesartan, over 2,000 patients again. If their blood pressure was systolic above 140 within 30 hours of either ischemic or hemorrhagic strokes, and they either got candesartan or placebo for 7 days. As you can see, there was no benefit one way or the other, but again, the trial design, if you look at the blood pressure effect, there was a minimal effect on the blood pressure. So unless the candesartan was working in other ways other than blood pressure control, there was obviously no benefit to be gained. So these American guidelines give a whole list of different drugs and indications and dosages, and these conditions, for example, and I'll touch on those in a few minutes, but a more UK-centric version, so talking about dissection and pulmonary edema and so forth. Okay, last few moments or minutes, UK-centric treatment. As I mentioned before, be familiar with a few drugs, and that's usually enough to manage most patients. Just to make a few mention of some drugs and problems with some of these drugs. Nitroprusside, a really good drug. It's gone a bit out of favour at the moment, and there's always this fear about cyanide toxicity, although it's occasionally reported but it really does seem to be a problem even if the drug is infused for more than 24 hours. The clue is if the patient's developing an unexplained metabolic acidosis because it blocks mitochondrial respiration. It needs to be shielded from light, and in the pack comes a sort of silver foil for the syringe and the tubing, and it may accumulate in renal failure, and potentially it may cause problems if the patient's got a raised intracranial pressure. Hydralazine is a drug that's been around a long time, and again, it's been very commonly and safely used in pregnancy. Nitrates, I talked about this in heart failure, but I think it's especially good when the patient has left ventricular failure or angina. Beta blockers are nice drugs, and there are now increasingly short-acting drugs like esmolol. There's a new one coming along called landiolol. That, the half-life of these drugs are minutes. Metoprolol by infusion, again, is relatively short, sort of minutes, but a bit longer than esmolol or landiolol. And labetalol has mixed alpha and beta effects, but the bigger you go up on dose, you'll get more of a beta effect than an alpha effect. And these drugs are especially useful when you want to reduce stress on the blood vessel. So, for example, aortic dissection, maybe there aren't the big trials in subarachnoid hemorrhage. Clearly, you need alpha and beta blockade if the patient's got a pheochromocytoma. And in heart failure, I think they're really good drugs if the patient is hypertensive and tachycardic. It improves diastolic function, reduces resistance against which the heart has to pump. But clearly, you need to keep a close eye on these patients because of potential risks of negative inotropy or excessive bradycardia. So a few specific conditions, as I mentioned earlier, for acute aortic dissections, ideally lower that systolic to as low as you can get it, but still maintaining organ perfusion. I think beta blockers are probably the way to go, and nitroprusside, again, is very controllable. Heart failure, nitrates, and think about careful beta blockade, especially if the patient's tachycardic. Pheos, I've just flagged up, there's this old paper, but a really nice paper from over 20 years ago, where patients may present with pheochromocytoma with paroxysmal hypotension. So in this study, it was about a third of the patients presented with hypotension. So it depends on which catecholamines are released. Some are vasodilating rather than vasoconstricting. But in general, for hypertensive emergencies due to a pheo, then you need alpha and beta blockade. As I mentioned, labetalol is often used, but as you push up the dose, there's more beta effect. Phentolamine is often used. Beta blockers like esmolol, metoprolol. And magnesium's been used successfully both preoperatively and perioperatively. And Mike James, who was Prof of Anaesthesia at Cape Town, did a lot of work on this. For subarachnoid, there's an evidence base to support the use of nimodipine, calcium channel blocker. Maybe nitride could be useful, or beta blockade. For eclampsia, preeclampsia, I think now, clearly, it's making sure the patient's not particularly hypovolemic. They don't need to be shouldn't be volume overloaded. Magnesium sulfate is now de rigueur the drug of choice, and there are lots of trials to show its benefits. Beta blockers, hydralazine, may also be used to lower that systolic blood pressure, and clearly if the child can be delivered, all well and good, and clearly the mother is prioritized, but clearly the child needs to be monitored closely as well. Perioperatively, again, there is potentially an increased risk of ischemic events, and depends on what type of surgery is needed. So if the patient isn't an emergency, the blood pressure can be managed as an outpatient. For urgent surgery, you can use short-acting intravenous agents like nitrates, beta blockers, nitroprusside, whatever. And for intraoperative hypertension, rapid short-acting intravenous agents are also good, so you can titrate as appropriate. Clearly, during the op and post-operatively, obviously you've got to ask the questions about volume status, pain, are they very cold and constricted down. Going back to the American guidelines, again, they give gradings as to what you should do. So patients with acute intracranial hemorrhage, so within 6 hours of symptom onset, the recommendation is not to lower the blood pressure unless the systolic is above 220, and then ideally use continuous IV infusion agents and close monitoring, and they gave that a 2A level of evidence. For patients with an ischemic stroke within 72 hours of symptom onset, so the question is, do they need or qualify for thrombolysis? If the answer is yes, what they recommend is to lower the systolic below 185 and the diastolic below 110 before starting the thrombolysis and maintaining that sort of level for the first 24 hours. If the patient's not having thrombolysis, as you can see, the little red box is there's no benefit from restarting the blood pressure, or if they're on antihypertensive treatment, provided the systolic is below 220. If it's above 220, it's take the edge off it, lower the blood pressure by 15% over the first 24 hours. For a hypertensive crisis in general, if there's new or progressive organ dysfunction, they recommend admitting to ICU. If the answer is no, you can then start them or increase their oral antihypertensive drug therapy. For those patients that go to ICU, obviously, you look for the cause, and sometimes you might need to be more aggressive in terms of your management. If it's, for example, a dissection or a pheo, lowering the systolic to below 140. If that's not the case, then you want to take the head off that high blood pressure, come down by about 25% over the first hour, and then between 160 to 110 diastolic over the next 2 to 6 hours, and then aim to normalize over the next day or two. And they gave that class 1 evidence, although I would argue it's probably not that strong. So I'll leave you with their recommendations, and be happy to take any questions. Thank you very much indeed.